introduce the topic a little bit. What do we actually understand under Black Swan events, Black Swan surgery? It's been around, the saying's been around since the ancient Roman times, but more recently, a Dutch sailor discovered the black swans. Until then, everybody believed, until the end of the 17th century, everyone believed that swans could only be white. And this translated into today's use of the expression, where we describe the black swan events as something that is highly improbable or extremely improbable, but has an extremely high impact. Swans come in many different colors, but for the purposes of risk assessment in the financial world, they have been divided into white, gray, and black. And the black swans are events that are unthinkable, but after they happen, they change completely our view of the world, and they become axiomatic. Such an event happened a couple of years ago. Sadly, similar events happen for turkeys each year. It's also a matter of who's observing the event, whether it's described as a black swan event or not. And to apply the metaphor into the surgical world and into the world of mediastinal lymphadenectomy, we would have to say that what stands for the event is actually a fact that's been known for decades now. It's that the contralateral lymphatic spread of the non-small cell lung cancer or any other lung cancer does exist, sometimes even as skip and 3 spread. And actually what we would like to talk about is the reaction to this fact or this event. Those are the bilateral mediastinal lymphadenectomies, techniques developed by quite a few excellent surgeons, Ramla, Temla, or in Japan, a couple of groups dealing with sternotomy and bilateral lymphadenectomy. It seems these surgeons are in the minority, and because the majority of the surgeons just keep saying, perhaps this white swan that you describe as a black one is just a little bit dirty, so let me change the species entirely, and we will actually deal with the inconspicuous gray rhinoceros, which are events also coming from the financial world, described as risks that we are unwilling to act on or unwilling to acknowledge that they are there. So should we ignore the rhino? Well, you might say we know so much about the mediastinum before we resect the tumor in the patient. We have a PET CT, we have the EBUS, we have selective EBUS mediastinoscopy. We can do intraoperative staging. But is it really enough? Well, we always compare these clinical staging methods with the definitive pathology, but that is almost always unilateral when it comes to comparing the lymph nodes. Only a few have dealt with the bilateral problem, and even then they have discovered that the negative predictive value of very well done systematic EBUS combined with EUS in very experienced hands yielded less accurate information on mediastinal staging. And thus, we remain with 10 to 20% of surgically upstaged patients, and there is always this dark side of the moon, the dark side of the mediastinum, which we never find out what's going on in. There are multiple anatomical studies, scintigraphic studies spread across the decades, which have analyzed this problem and discovered that there is a lymphatic spread that does happen to the contralateral side equally from the left side, as well as from the right side to the left. And the percentage can be quite high, as for the left lower lobe, up to 50%, or around 25% for the middle lobe. We are used to labels which make our everyday work easier, but we have to keep in mind that all these labels have sometimes been assigned to lymphatic nodes and stations and pathways and chains arbitrarily. That's why it has also been changing throughout the history of mediastinal staging. And there is practically sometimes very little anatomical correlation between what we design, what we assign to various lymph node stations and how actually the stuff in mediastinum works. There's also another question whether it's not the amount of disease in the lymph nodes that we should be looking for as a prognostic factor. We know that multi-level and one lymph nodes and single level and two lymph nodes have a similar prognosis, which we have also confirmed that in our small cohort of patients, shamelessly advertising the poster now, that there is a cutoff value for the number or percentage of positive lymph nodes of all the removed lymph nodes. If you do a thorough lymphadenectomy, there are two cutoff values which can give you some prognostic information on how the patients will be doing. This was almost the same in a multi-center study that analyzed retrospectively the correlation with overall survival and disease-free survival of patients who had less or more than 40% of positive lymph nodes. It's also a matter of divergence of the expression of exons and RNA content and the tumor cells, which keep branching off, and often there are alterations which would be very interesting for the targeted therapy. It's another reason why we should collect this information prospectively. The techniques that have been developed later, VAMLA and TIMLA, are less invasive than the sternotomy and allow for an excellent view of a certain number of stations. They're minimally invasive. Another advantage is that they are done under bilateral ventilation, which may, at least in theory, reduce the stress to the heart and lungs, the ventilation reperfusion injury, and also the immune response to the surgical stress. So there's a target group of elderly patients who might be frail to undergo a more extensive surgery. I've been thinking about the reasons why these techniques and methods have not been accepted very well, and they are not widespread. It seems it's a niche for some fanatics who like to dig around in the mediastinum and take out the lymph nodes. Well, the reasons might be that it takes time. It takes time to perform the surgery. It takes time to learn it. There might be, if we do it as a two-stage surgery, where we wait for the definitive pathology from these lymph nodes and then apply neoadjuvant chemotherapy, there might be quite significant fibrosis in the hilar region, which makes the resection technically difficult, which is especially in the area of vatsalobectomies of not negligible significance. There is a learning curve where you really have to start at the level of topographical anatomy to learn the relations between various heavily vascular structures in the mediastinum. So it might seem that it's a heavy investment with a marginal benefit. Who knows if there's a survival benefit for patients who are in the end N0 pathologically, and there is a non-zero risk associated. So I think these are the reasons. Also, for any future study, be it retrospective or prospective, it's impossible to define a homogeneous control group because we always leave the nose on the contralateral side behind. And how are we supposed to know if these nodes do or do not have any tumor cells within them, or changes that would be connected to tumor spread? So that's a principal problem, cannot be answered, cannot be dealt with. Some might say there's no need for lymphadenectomy for small tumors, which is also not true. So in our department recently, in the last 5 years, we have analyzed a partial solution where we would perform a single session VAMLA and vatsalobectomy. It's also a matter of reimbursement in our unit because we get reimbursed for each lymphadenectomy on both sides. There's better patient compliance. If we tell patients you're going to have just one surgery, there's no trouble with fibrosis. The patients do undergo a thorough clinical staging with selected EBUS, and the incidental nodes, incidental N2 or N3 situations are treated as adjuvant with adjuvant therapy. So looking at the results after almost 5 years of follow-up, there is no statistically significant difference for all other lobes and all other stages, but for the left lower lobe, we have noticed a significant difference, with VAMLA being patients undergoing VAMLA, which also has an anatomical correlation with what we know about the lymphatic drainage of the left lower lobe. There is a significant difference. However, there's a lot of censored patients, as you can see, and we would like to wait for some further developments to see whether this holds. To conclude, we should not ignore the rhino. You can feed it, you can tame it, you can do whatever you like, but don't ignore it and have fun with it. Thank you very much.